I'm Ashleigh Axios. I'm a business owner. I am an international speaker, although I'm an introvert, something you'll learn about me. My tendency is not to get up there and speak in front of people, but I do it because it's where my heart is, to help represent a diverse group of people, and it means going out there and being uncomfortable sometimes. And I'm also a board leader championing equitable healthcare, business design, and civic design. I'm the Chief Experience Officer and an owner of a business called Coforma, which is a digital services firm that crafts creative solutions and designs technology products that positively impact communities. And we work across the federal ecosystem, nonprofit, and commercial spaces. And 3 of our focus areas are around healthcare, which is relevant to my talk here today, veteran services, and immigration. I'm also on the board, a trustee member of Rhode Island School of Design, also known as RISD, which is a private art and design school based in Providence, Rhode Island, which is also where I got my BFA a while back. Prior to Coforma, I formed and led an in-house creative agency at Automatic, which is a tech company behind WordPress. Their mission is to democratize publishing and commerce. And I worked at the White House, the Obama White House specifically, as a creative director and a digital strategist working out of the Office of Digital Strategy. And you can see the ODS kind of symbol and logo here with that mission of connecting people with purpose, given the impact of technology on how people engage with one another. All right. I'm also an avid volunteer leader, as I'm sure many of you are as well. So I was on the board of AIGA, which is the Professional Association for Design, with a mission to advance design, and AIGA DC before that, where I helped form .gov Design, an initiative to empower government designers in particular, who really need the support and be bonded with one another in community and conversation, as well as with training and conferences, so that they could do their best work to support each of you with the services that the government offers. For those of you who can't maybe see me, I am tall, light-skinned, mixed-race woman, wearing a jumpsuit, curly hair, but got my hair up in a weird little kind of hair crown situation today, try to amp myself up. And as I've been told since the 4th grade, I have a distinguished or big forehead, so that's a little bit of a visual description. And then in that spirit of sharing a little bit more about who I am, just things that you can't see, I'm a survivor, I'm bisexual, I've been married for 10 years this week to my husband, Nathaniel, and thanks. And I'm a believer that the best things come, as I say, from kind of working hard, kind of living with integrity, really just putting ourselves out there. So with that, I'll get into this talk. You all ready for it? Yeah. Beautiful. All right. So if you're not from the US, bear with me, because this is all probably just shocking and very strange to you, but we're going to be talking about healthcare in the United States. Confronting stigma traps in healthcare. So the US kind of healthcare system really promises to improve quality of life and do no harm, and yet there are these stigmas that come up perpetually, time and time again, that really kind of enforce problems throughout the ecosystem. There's also this tension, right, where there's increased pressure on these healthcare systems to be more equitable, inclusive, and accessible over time, but that they have these legacies of separation that are making it really hard for them to create equitable systems of care and really meet that mandate of providing care and doing no harm to each of their wide audiences. So there's a tension here that we have to kind of work through. So in this talk, I'm going to walk you through some really popular healthcare frames that I think are highly problematic and share the reasons that those are problematic for us to kind of begin to break them down, and highlight the kind of neglected issues that I think those frames obscure over time, making it really difficult for folks to kind of get the care that they need. This is relevant to you all because we're all system shapers, and we all should be managing our wellness and health, and so it's particularly relevant to each of us as members of the community from that vantage point. So I hope you'll gain some new perspective. Whether you care about healthcare or not, I think you'll be able to apply some of these things in the spaces in which you operate, and be able to apply some of these principles that we talk about in your day-to-day work. In case this talk really just bores the hell out of you, I'm going to start with a couple of spoilers right up front to get some of the lessons in this thing out there. The first one is stop blaming the victim, or if you'd rather, the term survivor, or kind of injured parties for the things that they've experienced. Consistent across common healthcare language and these frames that we'll talk about later is this tendency towards victim blaming or kind of gaslighting these audiences for the issues that they're combating on a regular basis. These faulty systems that they have to face in order to get health care. Separately, as should be not kind of surprise to anybody in this audience or to anybody kind of watching this at home, the language we use matters. So it might feel like I'm nitpicking on a few terms that are used pretty commonly here, but this is incredibly important stuff. In many cases, the language you use sets the stage for the type of care people end up receiving, how we treat one another, and whether we're acknowledging or kind of justifying our actions. So we want to address our language really carefully. And perhaps it's not a big leap to imagine how this is especially important in spaces like healthcare, where we're trying to live the kind of best examples of what our work is capable of, but a few bad language choices extending across vast systems and embraced widely can really shift the mental models and systems enabling neglect or enabling successful delivery of care. But let's jump into the issues specifically. I'm first going to walk you through these 3 healthcare frames that I find highly problematic to begin to just really get into the meat of it here. First up is low trust. I've heard it said many times before that certain communities have issues of low trust that impact the relationship with healthcare providers and health systems, and therefore the quality of care that they end up receiving on the other end. The implication is that if these communities just trusted healthcare providers more, they'd receive better care and their health outcomes would be much improved. Whether those outcomes are related to vaccination or maternal mortality or something else entirely. The next frame we're going to spend some time talking about are kind of individual choice. It's said that many communities may choose not to engage with healthcare at all. There's a Forbes article where they talk about a Sapient Labs research project that said nearly 45% of Americans who have been diagnosed with a mental health issue do not receive or even go after any treatment or care for that mental illness. And many of these studies point back to the same core issue as the reason that they're not seeking care or getting treatment. It's, they have opted out, or kind of, quote, preference to manage their challenges on their own, unquote. But again, I think the implication here is that, folks are just moving away from care. They think they can do something better, but there's a deeper issue that we'll begin to unpack, because I don't believe that folks are just opting to go it alone. There are some core issues that this framing and focus within the healthcare industry is neglecting to dive into. And the third issue or frame that we'll talk about is this issue of health literacy. Raise your hand if you have heard of health literacy before. It's a few people. So it's said that this is one of the greatest barriers to healthcare in the 21st century. So it's important to know it, even though I don't particularly agree with it, and we'll talk through it. So what is health literacy? Personal health literacy is the degree to which individuals have the ability to find, understand, and to use information and services to inform health-related decisions and actions for themselves and for others. Now notice the emphasis on patients' ability here. For me, that's already a big red flag. It's people's ability to seek care, to understand, to care, to navigate care on their own, or to help others navigate care. And again, this is being pointed to across the healthcare ecosystem really broadly as like the major issue. People don't know how to read, understand, and navigate care all on their own. Should that be the goal? We'll talk through that a little bit more. This new layer was added, which has a lot of the same meat to it. It's a more recent addition, but organizational health literacy is pretty much those same principles of finding, understanding, and using information to enable care, but it talks about the degree to which organizations can equitably enable this to happen. So this is a positive change, at least, to talking about some organizational, systemic kind of support structures and systems to enable change. But for me, even the kind of existence of the personal health literacy layer is highly problematic. So it implies that kind of individual ability or competence is really an acceptable precursor to having quality healthcare. So these are the three main frames that I'm going to kind of challenge here. I'm sure that they'll help you think of maybe some others as well. But each of these are kind of problematic in their own ways. And a common theme for me across each of these is that they slyly shift the kind of blame away from the institutions and the systems to the individual or community level, really kind of shifting the blame to them for the harm that they're seeing or the lack of care that they're getting over time. And it's a particularly US issue when it comes to healthcare. So I'm going to share a story that's a little bit more personal here to help kind of tie some things together and give you a sense of how some of this can show up in a community level, because it's not really just about big organizations, it's about how it's affecting people. I'm going to share a story from my mom. I have gotten her consent to share this story. So when my mom was pregnant with my older brother, she was a nervous first mother, as I think a lot of folks are. She really didn't trust healthcare systems very much, but she knew there was so much that she needed to learn and figure out and navigate to be healthy and happy and fit all the standards when it came to her pregnancy and having my brother. So she otherwise didn't visit a doctor frequently. She, like I think a lot of folks in the US, went to the doctor when she needed to go to the doctor for reasons like cost or sometimes lack of insurance. But she kind of opted in whenever she needed to. She also had an experience when she was younger getting injured that made her a little weary of doctors. She didn't get the best treatment. She probably had a concussion at the time, and they were like, "You're fine." Not the greatest experience. So here you see a photo of my mom and her younger brothers, my uncles, when she was a kid. So another layer for her is, despite the effects of seizures, she has epilepsy, on my mother's memory, which shook her confidence and made it a little bit hard for her to know, to feel like she was the most competent person in the room when it came to engaging with doctors and people with the most credentials. She went to the doctor early on in her pregnancy. She got guidance for medications she should be taking and shouldn't be taking, for what her nutrition should be, her activities should be, and she was highly engaged throughout the process. She was also careful and kind of went through all of the fetal health checks and checked in with her internist as well as her general practitioner. So she was participatory in the process despite the fact that she mistrusted doctors. Her preference would be not to go to the doctor frequently, right? And only when she really needed to. But she engaged fully in the process and even drove discussions, actively asking questions and trying to get as much information as possible. Near the end of her pregnancy, during one of her routine health checks with her internist, she brought up her medications again, and specifically brought up this medication, Dilantin, which she'd been taking at 250 milligrams 3 times a day, which is a lot. And this is a anticonvulsant that was part of her seizure treatments that would prevent her from having grand mal seizures. So really important to take on a regular basis. But she's like, she knew this stuff was strong. She had checked in before. She just wanted to check in again and make sure it was going to be okay with her pregnancy. Although it wasn't the first time she brought it up, the doctor's reaction was incredibly different this time. He freaked out. He said, no, you absolutely should not be taking this medication. You should have not been taking it at all during your pregnancy, and went through all of these things that might be happening because she had taken it. So my purpose here isn't to scare you, but give you just one real story of how this type of thing affects people. So she found out, there was a chance of fetal death from taking this medication, and it's already been months and months. There's nothing she could do about it then but stop taking it. When she confronted and asked him, why didn't you tell me this when I asked you the first times? He was like, I had no recollection of you asking before. It's not in the record. I don't know what you're talking about. So she felt completely powerless. She was engaging as best she could throughout the process and still hit with this, feeling of complete and utter lack of control, complete fear. So fortunately, my brother was born. It was perfectly fine. So I'm going to close the loop on that before I move on to other points on this. Healthy baby boy. Here's my mother with my older brother at the zoo when he was very little. And he has been healthy and continues to be healthy. Here he is with his family, his wife and his 2 kids. So don't worry about him. That turned out fine. But these stories, right, that's not necessarily what you'd expect to have happen out of a story like that. That's terrifying. And so my mom was not alone in having a lack of trust for her doctor, and particularly within the Black community across the US, there's a shared knowledge of these types of risks and stories that happen that really contribute to a reluctance to engage with medical providers, even in those instances when folks feel like they know they're supposed to. It's a gamble. It's a real risk. You don't know what you're going to get. You don't know what isms are going to kind of come into play in those moments. So medical establishments and clinicians all know this, so perhaps there, maybe some cause or reason that they might put so much emphasis on mistrust as a major reason that people aren't engaging with their healthcare providers, right? Still, I don't think so. Their mistrust is there, but it's not the root issue. I think putting the emphasis on mistrust as the issue really obscures those deeper issues in play, right? The deeper issues of the kind of abuse, of not being listened to, the gaslighting that's happened that has led to the mistrust. It's to focus on the feelings while ignoring what's caused those feelings in the first place. And we can't really address the mistrust until we get back to those root problems and begin to address each of those. So I'm going to go a little bit deeper here, a little bit of history, because I find this stuff really fascinating. I think it's important to set some of that kind of grounding. But throughout American history, horrific stories of the medical establishment abusing the Black community are rampant. From the so-called kind of, quote, father of gynecology, unquote, physician James Marion Sims of Alabama, pioneering surgical techniques on the unconsenting bodies of enslaved Black women without anesthesia. Of course, there are no ethicists at the time to tell him what's right or what's wrong. He was experimenting on slaves, so I don't think that was top of mind for him anyways. But really leaning into kind of broadening the medical field at all costs. And he's been celebrated for years. Here he is in a photo with medals adorning him. He's highly celebrated even today. But all of the innovations that he made were on the backs of Black women who were enslaved without care for the communities or the impacts on them directly. Many of those went on to benefit financially the medical establishment, which is primarily kind of white male doctors, to the exclusion of midwives and all sorts of industries that had been around and thriving prior to this time. And his techniques would go on to benefit kind of white women, not even being able to benefit Black women on a scale for hundreds of years to come. So the cost and the labor and who's really paying for that innovation is a deep part of history and really deeply intertwined with the medical systems, particularly in North America. And that's just one example. It might be easy to go, oh, that's kind of rare, or that's just one thing, and to kind of put it aside. But I'd also point to things like Henrietta Lacks and the Tuskegee syphilis experiments, as well as just the segregation of hospitals in the United States until 1965, which is really not that long ago, let's be honest. So this is a pattern of bias that's affected the understanding and just the makeup of medical establishments. And I'd do a disservice if I didn't point to some other communities as well. So Black mistrust is not the only well-reasoned mistrust that exists for medical establishments. For many American Indian and Alaskan Native communities, the history of trauma, ethnocide, genocide goes just as deep. There are examples of forced sterilizations where a woman on tribal land would go in to get support in one of the facilities to have labor in case of complication, and after having the baby would end up having her uterus taken out without her consent or without conversation. A rich part of this fabric and history also included this idea of, quote, save the man, kill the Indian, unquote, which meant shifting folks to a Eurocentric version of what was acceptable. You see an image here of a Navajo student who went to a boarding school, and a lot of the programming and the systems in those schools were all about removing his culture and heritage to make him more accessible by a white standard. And these, I think, are becoming more common knowledge these days with some of the boarding schools and the, this is hard, heavy stuff, so bear with me for a Friday. But with the bones that were kind of dug up of these children that have died in the process across North America, it's becoming a little bit more common knowledge. But I think there's still a lack of acknowledgement of some of the ways that this was embedded in our medical establishments and our systems and institutions at a deeper level, and not just our education systems. So when it comes to our medical establishments, they were also intentionally getting rid of the healing and traditions of each of these communities in favor of white, kind of Eurocentric standards. Oh, so those are just a few examples. Feel free to shake it off. I know it's heavy stuff here. But this stuff largely has been on the backs of the kind of BIPOC community in the United States. So I have to insist that BIPOC communities kind of not trusting the medical establishment is not a problem in itself. It's a symptom of a deeper problem, right? You can get just how layered and just how complicated this really is. So medical institutions prioritizing mistrust, like, oh, we just need to get you to trust us, is really not going to work. It's not going to address, and it's not going to be appreciated when it doesn't fully acknowledge those deep, rich histories. And I get particularly mad and passionate about it, which is why it's a talk here, in part because I see so many people who are well-meaning, who believe in those ideals of kind of human-centered design, and who believe in those ideals of, really improving health and wellness across a larger ecosystem, and who believe in equity and inclusion and access, who still fall into some of the traps of using these terms and kind of focusing on these issues that are kind of, I think, meant, whether intentionally or not, to create a kind of barricade between the real issues. And as designers and system builders, I think there's a tension and a skill that we're able to bring to these types of issues if we're given the chance. So what about individual choice here, that second frame that I was talking about earlier that I think is problematic? And this, again, is that idea that communities just choose to opt out of care. Obviously, the mistrust is one reason. Digging into all of those reasons for mistrust, those are all the same types of reasons that somebody might opt out of healthcare. But I think it's important to also acknowledge the many other reasons, core issues that folks opt out, including the high cost of healthcare, insufficient insurance coverage, limited healthcare options, long wait times, lack of support, right? Somebody to do caretaking, caregiving responsibilities so one can get treatment that they need, lack of kind of knowledge of services that are even available, social stigmas around treatment for particularly some of the more nuanced ailments that are out there with society's perception of them, and a lack of physical access, which can include anything from transportation to geography, and is certainly made worse by climate change, right? Our work at Coforma, we did some work to understand how close facilities for health treatment were for Native communities in different regions, and just the amount of time that ice melt is longer, and not being able to, for example, in Alaska Native communities, transverse ice to get to a facility. It used to be 20 minutes, would now be multiple hours to go around an area because it's not frozen over in the winter. These are all those complex, deep-rooted issues that are the, real issues underneath why somebody might opt out. And so these are systemic problems. They're not the responsibility of just the patient or community. They're not an individual problem to solve, to just address on their own. They're the types of things that are systemic barriers to care across payment and access and adequate customer experience, as well as issues like bias and social stigma. So it can be easy to point to the symptom, but we should go deeper into these issues. So let's go back to health literacy again for a moment, that idea that folks can use and access care if they had the right understanding and level, that literacy level, in order to fully engage. So if someone isn't able to get care because they can't understand the materials, that's a problem of the institution, I would have to insist, and not that individual. There should be no amount of literacy that's required for somebody to engage, right? A baby, a child, we don't expect them to read materials on their own. They should get care. Likewise, there are many reasons why somebody might not have the highest, even reading comprehension, English literacy, in order to navigate care. And a real caring system should be able to help them navigate those challenges. So, also shouldn't require a medical degree. To give you examples of some things that come up with health literacy, it's being able to read and follow directions on prescription drugs, to navigate and understand test results on their own, or insurance forms. I don't know about you, but I have gotten directions as a college-educated person who helped with the rollout of the Affordable Care Act and other healthcare issues, and I have not been able to navigate them at times, right? Whether this is due to dark UX patterns or just, poor communication, poor writing on those forms. Even those of us who have the most privilege and access and have gotten the most support and education can have a difficult time doing some of this stuff. Put on top of that, the maybe inability to navigate it because you have brain fog, as they're calling it now, from long COVID, or because of the symptoms of the sickness you're fighting to begin with. To say that that should be a requirement for people to get the highest quality of care is to really not understand or appreciate the nuances of why people need care in the first place. So I would go so far as to even say that patient health literacy as a framing is a byproduct of eugenics, which has, again, deep roots in the United States. It's to kind of put that blame for systemic failure on individuals and say, really, wouldn't it be great if individuals were perfect? Because if individuals were perfect in all these standards and ways that we've set out, all of this would be really straightforward. You just have to rise higher to meet our standard of perfection for individual performance so that you have the best medical care. And this is being used to kind of discriminate or justify why certain communities have better health outcomes than other communities do. So it's critically important that we really break this issue down. Again, that word ability in there is a kind of a good signifier and a red flag and an indicator for me that people should have the ability to participate and conduct all of those things. So health literacy assumes kind of the clearest mindset and being at peak performance, having home or shelter and transportation and internet and all of these things to be able to perform at the highest level all of the time. That it assumes any of this is completely wrong and unfair and unjust in the society as we have it built today, where not everybody is afforded each of those kind of privileges. One last point on this is just, maybe this could be a whole talk on its own, but human-centered design, I think we have a tendency to put so much on the people and to connect it back to people in really beautiful and empowering ways. And I would just caution that in the healthcare space, we have to be especially careful because it's not the people who need fixing. We need to focus a little bit more on the systems to enable people to be their best self, knowing that they're coming from completely different communities, standards, and what wellness looks like from one individual to another is going to differ, and that's okay. People don't need fixing, right? We don't want to, again, lean into that eugenics mindset, ableist mindset. We really need to respect disabilities and differences. All right, so hopefully this talk isn't too bleak for you. There's much, I think, that we can actually do to combat these issues together. So I'm going to talk through those for just a few minutes, really leaning into the systems thinking a little bit, knowing that you can find ways to apply this, whether you work in healthcare or not. So what are some things I'd like us to do? Really take time to understand the history in each space that we operate in, collaborate with communities on culturally aligned materials like communications. None of those should be generated on one's own or from just one's own perspective, and make no assumptions or set no minimum standards. And I've given some examples here that tie to things that we've already talked about, but literacy, language, education, trust, wellness, rest. And while I'm talking, again, specific to healthcare, these are things I think apply. Challenge me if you don't agree, but I think they apply pretty universally to the types of things that we would create and enable. Point again to the root problems. Hopefully you're already doing this, really leaning into user research, but make sure that we're working on the core issues. Separate people from problems. We don't want to make things about the person that don't need to be about the person. When we're looking at the issue, know that the person is not the issue, specifically in particular in the healthcare ecosystem. And then make communications that feature plain language and test those with diverse representative audiences, customizing with and for those communities. And then at the heart of this whole talk here is this idea that we should be careful of industry-specific euphemisms that can obscure issues and harm communities, in particular those communities with less kind of power and access over time. So if you like this talk, you may be interested in some work that we've done. We have really thorough documentation at CoForma on recruiting for diverse audiences and engaging really deeply with communities who don't have trust, who may be weary of research, even as an idea, as we have a little bit in our work at CoForma. So I've pinned a bit of guidance that we have to my LinkedIn profile, if you'd like to check that out. And you may also be interested in just keeping an eye on what we're doing at CoForma and some of the work from improving veteran services to enabling better access to immigration. We supported the Presidential Task Force on Family Reunification to help reunite families who were separated during the zero tolerance policy of the Trump administration, as well as supporting the COVID-19 Health Equity Task Force last year and getting to some of the root systemic issues to help prevent and mitigate the issues during a pandemic at a much deeper level. So thank you all so much for your time. I think we have just a couple minutes for Q&A.
Thank you so much, Ashleigh. I feel like I need to tread lightly because I don't live in this country. I live in the UK where we have National Health Service, which has all sorts of problems. It's chronically underfunded, but it does have an underlying principle, which is that care should be free at the point of service. And when people talk about defending the NHS in the UK, often what they do, the point is like, we need to defend the NHS because the worst case scenario is, well, look at the USA. It's kind of seen as an anti-pattern. When you talk about the systemic problems with the US healthcare system, do you think the US healthcare system needs to be tweaked and adjusted, or does it need to be fundamentally altered?
I mean, I think it needs to be fundamentally altered, but we're so far off in so many ways that I think even just acknowledging the deep history and injustices and beginning to really have a kind of almost our own truth and reconciliation is the best kind of starting point across the landscape. But it needs to be rebuilt from the ground up. And I think there have been lots of proposals and models and different ways to do that. And it's in part, I think, because of a lack of understanding of some of those root issues across the US that hasn't been maybe as fully embraced. It's hard to know what you're missing when you have only known this system. To know that you could have, universal care and be a partner in getting that care with others, to have standards and measures of success that aren't so discriminatory between audiences. All of that, I think, feels like such a stretch, unfortunately, to many Americans who just can't even fully imagine what that would look like and what that would feel like on a regular basis.
Yeah, we heard this morning from Natalie about capitalism, and I mean, personally, I think free markets are fine for selling gizmos or providing some services, but healthcare, like, it feels like a fundamental mismatch.
I mean, it could be for profit, it could be built in a national service. I think there are many ways to do it, but like this isn't it. We can all agree, right? Right now it's kind of a weird hodgepodge where we have highly commercial markets and very little oversight, and sometimes it even feels like government accidentally incentivizing corporations in all of the wrong ways on like trademarks and only, and medications only, to be the best producer of some of those things instead of measures of wellness and care and equality and some of those base levels that are really necessary. So I don't think, I think there are ways of doing it that work in capitalist, kind of fully embracing, capitalism. And I think there are certainly models that are more of a kind of communist take as well, in that, you don't have to think of communist in a political sense even. I know some people go straight to the political, but in that like shared community value sense. And there are probably hybrids in between that as well.
I want to go back to the stories you were talking about, kind of the attitudes of healthcare professionals, the victim blaming, that kind of thing. There's a book by Matthew Said called Black Box Thinking, where he compares two different industries of aviation and healthcare, and their attitude to learning from mistakes, and they're very, very different. In the aviation industry, you're rewarded for admitting you made a mistake, and there's incentives, and it's the exact opposite.
Yeah, they're like, litigation,
Exactly.
Don't apologize for anything. It's like, you severed their spine. They're like, shh.
Yeah. Can that change?
I think it absolutely can. It's about incentives, and we just haven't set up the right incentives in the US. And it just is as simple and comes down to that. And it wouldn't be that hard to, especially in a capitalist market. You can change some of those incentives and put markers and achievement that would really help drive corporate change really quickly on how they do things. But yeah, it's a shift of mental model, and it takes acknowledging it just has been very slow to have happen in the US. I think there's so much to grapple with and deal with that folks want to run away. Sometimes I feel bad even sharing this stuff. Like, I'm looking at you all kind of like apologizing for bringing it up, but also I'm so mad about it, and I want us to fix it, and I want us to acknowledge it, and I feel like it needs to come up somewhere. So it's a weird kind of tension and dichotomy.
I mean, from that perspective, it sounds like the healthcare professionals, the doctors, are as much victims of the system as anyone else involved.
Yeah, in some cases, I mean, you hear about folks that try to create system change in massive institutions and hospital systems, and they can't be heard and can't get the support to have happen. I think there's some really well-documented examples of, we're in New Orleans. I've been thinking about hospital systems in New Orleans and kind of what happened during Katrina as well. And there are all these stories of people who tried to make change and just very privatized hospitals not working well together, not enabling success, and it makes things incredibly difficult across the board. The same vein, there are also doctors and medical providers who just use that system, use these for their benefit, who Sims was a very early example, right? But he was a physician and he didn't really care about whether he was doing harm to others. He just wanted to make a name for himself and position himself to create a legacy. And he certainly did that, but to what end? It's unethical, really terrible. I mean, I don't know about any of you. If you hadn't known that before, you might think a little differently. Some of us going to the OBGYN, kind of thinking about it from a new light, but there's certainly folks that have also played into that system and used it for their individual benefit as well.
You said it really makes you mad.
Yeah.
How do you not despair?
I mean,
do you?
I do sometimes. I'm human. For me, I just keep pushing forward. I feel a little bit like a shark where by seeing progress and by continually moving, I'm able to kind of feel like I get some breath out of things. By sharing this with other people and by doing my small parts to make a difference, I feel like I've found a space in order to kind of survive. But I'll be honest, like I suffer from deep depression. I feel like I'm very aware. I'm one of those people that digs in really deeply to these issues, and it gets really hard sometimes because these are things that are going to be multi-generational to get solved. They're not going to be solved overnight, and it will take certainly way more than just myself or just my company and a few others doing this work. It's going to take massive cooperation and real, like I said, acknowledgement and investment in changing things and flipping things on their head. But yeah, sometimes I do, frankly, get super, super depressed about these things. And then I feel better because we're able to contribute to such amazing projects to help make a difference. And seeing what the Health Equity Task Force was able to put forward to President Biden in just a few months' time, not just looking at, okay, we need more PPE and masks during the pandemic. We need to figure out systems for distributing vaccinations more quickly, some of the more straightforward things, but really digging into those root issues a little bit more to acknowledge issues like trust and to talk about misinformation and why it's so easy for some to fall prey to misinformation and how we need to build infrastructure to account for these types of things instead of burying our heads in the sand and pretending that these types of issues aren't happening and aren't going to perpetually happen without intervention.
Yeah. Well, Ashleigh, I think I speak for everyone here when I say thank you very much for sharing with us today. Ashleigh Axios.
Thanks, everyone.